Hello, we are so thankful that you all are here today. Please give us a few moments to allow others to join, and we'll be with you in just a moment. Thank you again for joining. We're very excited that you're here. Again, if you're just joining, please hold on just a moment. We're so happy that you're here. We ask that you please hold on just a moment while we let others in from the waiting room. Thank you. Thank you so much for waiting, and we really appreciate you joining us today. We're so thankful that you have joined us, and we're excited about the presentation today. We are going to be presenting a presentation called Addressing Substance Use in Maternal Health Within Tribal Communities. And we have some great presenters today, and we're really looking forward to it. Just a few housekeeping items before we begin. We ask that if you have any questions to please put those in the chat. We can address those at the end, or you can have an opportunity to ask them at the end. Hopefully we will have enough time to address all of them, but if not, then if not today, then we will follow back up with you and address your question. Another thing that we've asked you to do today is that if you could please put your name and where you're from in the chat. We'd love to be able to know who's on here with us, and we'd love to just hear from you all as much as we can. So we really appreciate you putting that information in the chat. Again, thank you so much for being here today. And I would like to introduce Chief Stephen Atkins. He is from the Chickahominy tribe out of Virginia. Chief Atkins, would you please open us up with your opening prayer? Thank you very much. Chief Atkins, I think you are on mute. Thank you, sir.
Thank you. So,
to
the Health Resources and Services Administration, I appreciate you providing this forum for us to learn more about how we can attack this all pervasive drug use that goes through our communities. So I bring you greetings from the Mid-Atlantic Sovereign Tribes. Mushe Wanato, Chesketa Kwak, Woshawa Womananut. Great Spirit, loving Father, Creator of all things. We come to you acknowledging your love, mercy, and grace. Today, we lift up the efforts of the Health Resources and Services Administration as they work to promote the awareness of the substance abuse challenges regarding maternal health within Indian country. Father, we look to the east each day as we greet the rising sun with full faith, knowing you will drive out the darkness and illuminate your world. Even as you drive out the darkness to separate day from night, we pray that your light causes full awareness of the evil presence of illicit addictive drugs that continue to harm our community, including injury, compromised health, or death to our fellow native citizens. Father, we recognize you know us by name. You know your young mothers and your babies. Father, we pray that your light will shine into the world of academia and promote knowledge and understanding among students and open their minds in a way that will allow them to apply their knowledge in an effort to eradicate substance abuse among our maternal population. We ask that your light encircle health practitioners to enable them to bridge existing socio-economic and language barriers to healthy communities in a way that conquers the reality of substance abuse use in maternal health within tribal communities. Finally, we look to the west as the daylight wanes, with full faith that your grace will allow us to rest through the night and greet the sunrise. And when morning comes, we will approach this with renewed vigor and commitment to educate our brothers and sisters in the country in a way that steers them away from drug use. So, Father, I thank you for the health practitioners. I thank you for those folks who are working to eradicate this plague that exists. Father, give them knowledge and strength, a task that seems daunting, yet they remain undaunted. So, Father, please give them the strength and the courage to stand up. Many of them have taken the Hippocratic Oath, Father, and they live by it. So we thank you for the energy. We thank you for the work that's going to put this on today. And Father, we pray expecting that tremendous positive results will ensue. In your son's precious holy name, we offer this prayer. Aho. Thank you.
Thank you very much, Chief Atkins. Rachel?
Thank you, Chief Atkins, for sharing those opening sentiments on this important topic. We appreciate your time today. Good afternoon or good morning, depending on where you're joining from. My name is Rachel, and I will be one of the moderators on today's session, hosted by HRSA's Office of Intergovernmental and External Affairs on addressing substance use in maternal health within tribal communities. Next slide. Our goals for today's webinar are to provide information on HRSA programs and resources, examine the impact of substance use in tribal health within tribal communities, develop and foster new relationships between HRSA IEA and tribal partners. We also have several objectives that we would like to accomplish listed on the slide as well. Next slide, please. We have a full, very exciting agenda planned for today, including HRSA's Office of Tribal Affairs, the Maternal and Child Health Bureau, the Federal Office of Rural Health Policy, and 2 HRSA tribal grantees, the Menominee Indian Tribe of Wisconsin and Healthy Acadia, who will be sharing their experiences applying for and utilizing HRSA funding opportunities. First, I'm going to kick off the webinar by sharing a bit about the Health Resources and Services Administration. Next slide. HRSA's mission is to improve health outcomes and achieve health equity through access to quality services, a skilled health workforce, and innovative high-value programs. Through HRSA's more than 90 programs and 3,000 grantees, tens of millions of Americans receive quality, affordable health care and other services, including people living with HIV/AIDS, mothers and their families, and those otherwise unable to access quality health care. Next slide. HRSA's work expands access to healthcare services in the communities that need them most, including affordable primary care provided by HRSA-supported health centers and health professionals who received HRSA scholarships or loan repayment assistance, HRSA-funded prenatal and postnatal care, voluntary home visits, HIV care and treatment services, rural primary care, and substance use treatment programs, and much more. Next slide. Now that you know a bit more about HRSA, I would like to introduce you briefly to HRSA's Office of Intergovernmental and External Affairs, or IEA. Next slide. HRSA IEA serves as the principal agency lead on intergovernmental and external affairs, regional operations, and tribal partnerships. We achieve this by leveraging the knowledge of the national and regional landscape and networks of local contacts in states, tribes, and territories. There are 10 regional offices spread across the nation, with a headquarters office in Rockville, Maryland, and a sub-office in Puerto Rico. So feel free to take note of which contact here would serve the state in which you reside for a first initial touch point. Next slide. HRSA's Office of Intergovernmental and External Affairs works across all of HRSA's program areas to extend the reach of the bureaus and offices and to provide an additional touch point for HRSA's partners. Our work can be categorized by these core functions on the slide. As ambassadors and liaisons, we serve as a central point of contact and representative for HRSA and facilitate connections between HRSA and federal, state, local, tribal, territorial, and community partners. We assist to broker relationships with and among partners, addressing needs, facilitating problem resolution, advancing HRSA priorities, and leveraging HRSA resources. HRSA IEA also promotes public health and health equity by expanding knowledge about HRSA's programs, resources, priorities, and related best practices. And finally, we identify critical ground-level public health information about national, regional, local, territorial, and tribal trends to inform HRSA's operations, decision-making, and allocation of resources. Next slide. In addition to the headquarters and regional offices, HRSA IEA also consists of the Tribal Affairs Office, which brings us to the next part of our program. I would now like to introduce Dr. Juliana Blum, the new director of HRSA's Tribal Affairs team. Dr. Blum coordinates and advocates for tribal health across HRSA, and her efforts build on years of experience as deputy director of the Tribal Health Research Office at the National Institutes of Health. We are pleased to have her on this webinar to share some opening remarks and updates from the Office of Tribal Affairs. Please note full bios for our speakers will be shared in the chat for you to learn more. With that, I will turn it over to Dr. Blum.
Great. Thanks, Rachel. I really appreciate that. It's a pleasure to be here today. I joined HRSA last year from NIH, as Rachel indicated, where I worked for Dr. David Wilson, an enrolled member of the Navajo Nation. So I had quite a bit of good mentoring, which I really appreciated. I'm really pleased to be here at HRSA now, where I feel that so many of our healthcare priorities align with those of tribal nations. And one thing I'd like to stress today is that HRSA is really refocusing its efforts on tribal nations and looking for opportunities to increase our engagement with American Indian, Alaska Native communities. And to that end, our administrator, Carol Johnson, recently met with the National Indian Health Board's Board of Directors. So our administrator asked tribal leaders, how can we work better with you to address the critical needs in Indian country, including maternal and child health, substance use and mental health, and the healthcare workforce? So we heard a number of recommendations and are looking forward to continuing our conversations with NIHB and tribal leaders as well, so we can make steps in the right direction. One of the things I do want to bring to everyone's attention is that we're having our tribal consultation May 19th of this year at the National Indian Health Board's annual conference on tribal health. We're very excited. We're going to be talking about updating our tribal consultation policy to make sure it aligns with the new HHS tribal consultation policy, which was updated in 2023, and also to make sure that we're meeting the executive order from President Biden, which has uniform standards on tribal consultation. So we want to be sure that we're in alignment with both of those. So that's very exciting. We're also going to be discussing the health professional shortage area scores, which we know are used by the National Health Service Corps program to determine priorities for assigning primary care, mental health care, and dental care professionals. So that's something that should be a very interesting discussion. And we're really encouraging all tribal leaders and community members to attend and provide us with input and guidance on that. So the consultation itself, again, will be on Monday, May 19th at the NIHB conference in Rapid City, South Dakota. We also wanted to let you know that we're bringing together our Tribal Advisory Council for an in-person meeting in July in Washington, D.C. We are very lucky because we have almost the entire council filled. We have one seat that's open for the Great Plains area. So if anyone is interested in being nominated for that, there will be details in the chat, but we are looking for applications. So we want to make sure we have representation from all of the 12 IHS regions so we can get the most meaningful input that we can. Lastly, one thing that's not here on the slide, but I did want to mention it, is our new Enhancing Maternal Health Initiative. So this is, while there's no funding associated with this initiative, we are making an effort to bring together already funded HRSA grantees with partners in the different regions so that we can leverage the funding we already have out there, so we can strengthen our efforts to reduce maternal mortality and maternal health disparities in Indian country. We know that Native women are 2 to 3 times more likely to die from pregnancy-related causes than their white, Asian, or Hispanic counterparts. And this is frankly just unacceptable. We have to address this. As a result, HRSA is planning 2 panels that will be convening to focus on American Indian and Alaska Native maternal health to bring increased attention to this issue. Those panels will be held this summer. The first one will be in Arizona in June. We are looking to hold a second panel in Montana The location and date has not been chosen yet for that. Lastly, I just want to close out and encourage you to be sure to, if you have any questions about HRSA programs, or you need technical assistance, or just have questions, or even if you want to get to know us better, I would encourage you to reach out to the regional administrators. You saw their photos and the regions they serve on a slide previous to this. And don't be shy about reaching out to headquarters either. We are always happy to talk to you in the Office of Tribal Affairs and headquarters to find out what's happening, what you need help with, what we can do to support you and your communities. So please don't be shy. We're trying to build those relationships, so we're always happy to hear from you. So with that, I'm going to turn it over to my colleague, Elizabeth Fourmonier with the Maternal Child Health Bureau. Thanks.
Thank you, Juliana. Good afternoon and good morning. My name is Liz Fourmonier. I'm the Director of the Office of Policy and Planning at the Maternal and Child Health Bureau, also known as MCHB. Thank you all so much for this opportunity to present to you today. I want to tell you a little bit about our work in general and how our work supports tribal communities. Next slide, please. One more. Thank you. At MCHB, our mission is to improve the health and well-being of America's mothers, children, and families. And you can see our vision and strategic goals outlined on this slide. Next slide, please. MCHB strengthens public health systems to meet the needs of America's mothers, children, and their families. And we reach more than 58 million pregnant women, infants, and children, including children with special health care needs. MCHB funds national, state, and community organizations and academic institutions to improve public health by building maternal and child health leaders and the maternal and child health workforce across the nation, supporting data and research to measure and improve services for maternal and child health populations, and supporting programs that work together to improve health across the life course. Next slide, please. Every year in the United States, thousands of women experience severe, unexpected medical conditions, or even worse, lose their lives from causes related to pregnancy. Pregnancy-related mortality has not improved over the past decade. And if we look at these numbers, several trends emerge that tell the stories of numerous health disparities based on things like race and where a mother happens to live. For example, you're more likely to die if you are Native Hawaiian, Pacific Islander, Black, or American Indian, Alaska Native. And you are more likely to die if you live in a rural county where people often lack access to healthcare and services. Mental health conditions are the leading underlying cause of pregnancy-related deaths, and these are deaths due to causes such as suicide and overdose or poisoning related to substance use disorder. MCHB is helping to improve behavioral health through several programs, including the Pediatric Mental Health Care Access Program and the Screening and Treatment for Maternal Mental Health and Substance Use Disorders Program. Next slide, please. So through the Pediatric Mental Health Care Access Program, we call it PMHCA for short, pediatric mental health care teams use telehealth to provide consultation, training, technical assistance, and care coordination support for pediatric primary care providers to better address the needs of the children that they're serving with behavioral health conditions. PMHCA recipients focus on achieving health equity related to racial, ethnic, and geographic disparities in access to care, especially in rural and other underserved areas. And HRSA right now supports 2 tribal pediatric mental health care access awardees, the Chickasaw Nation and the Red Lake Band of Chippewa Indians. To date, the Chickasaw Nation PMHCA team has received and staffed a total of 492 centralized requests serving 500 individuals. And the Red Lake Band PMHCA conducted a Train the Trainers retreat on an Indigenous health toolkit. And they're also collaborating with the Minnesota PMHCA program and psychiatric assistance line to optimize data collection for tribes. Next slide, please. HRSA supports 12 states through our Screening and Treatment for Maternal Mental Health and Substance Use Disorders program. Like PMHCA, the program leverages telehealth to help primary care providers identify and treat conditions, this time for mothers in rural areas. The program strengthens healthcare providers' capacity to screen, assess, treat, and refer pregnant and postpartum women for maternal mental health and substance use disorders. The program provides psychiatric consultation, care coordination support services, and training to maternity care providers. In FY22, providers received expert consultation for over 1,800 pregnant and postpartum women. And in FY23, the program was recompeted and expanded the list of eligible entities to include Indian tribes and tribal organizations in addition to states. Next slide, please. I'd like to highlight a few other programs that work to improve maternal health outcomes and reduce associated disparities. Next slide. Okay. So the Maternal, Infant, and Early Childhood Home Visiting Program funds states, territories, and tribal entities, which include tribes, consortia of tribes, tribal organizations, and urban Indian organizations, to develop and implement voluntary, evidence-based home visiting services for pregnant women and parents with children up to kindergarten entry in communities at risk for poor maternal and child health outcomes. Since 2010, the home visiting program has been critical to supporting positive parenting, improving maternal and child health, promoting child development and school readiness, promoting economic self-sufficiency, connecting families to the services they need, and preventing child abuse and neglect. Currently, home visiting awardees in 8 states fund tribal organizations to provide home visiting services to their communities. Those states include Arizona, Montana, Nevada, North and South Dakota, Washington, Wisconsin, and Wyoming. Additionally, HRSA works with the Administration for Children and Families to implement the tribal home visiting program. And in FY24, $33 million will be allocated to the tribal home visiting program. We also call it MCV. The program supports 41 grants serving 68 tribal and 17 urban Native communities. The Healthy Start program uses community-level strategies to improve health outcomes before, during, and after pregnancy and reduce disparities in maternal and child health. The program provides grants to communities at higher risk for poor health outcomes immediately before and after childbirth. Currently, HRSA supports 111 Healthy Start Award recipients in 35 states, DC, and Puerto Rico, including 2 federally recognized tribal communities, Great Plains Tribal Chairman's Health Board and Intertribal Council of Michigan. Every Healthy Start project partners with community leaders and organizations, health and social service providers, faith-based leaders, local business representatives, and residents to address the community's need. Healthy Start awardees provide care coordination and outreach for prenatal and postpartum care, programs for screening, referral, and follow-up care for depression and substance use, parenting skills, and well woman care and maternity care services. HRSA's Family to Family Health Information Centers program provides funding to 3 organizations serving tribal populations, in addition to 5 territories, 50 states, and the District of Columbia. These family staff centers assist families of children and youth with special health care needs in making informed choices about their child's care through one-on-one assistance, training, guidance around their child, information sharing, and referrals. And the State Maternal Health Innovation Program funds public health departments and universities to improve maternal health in the United States by establishing state maternal health task forces, improving state-level maternal mortality and severe maternal morbidity data, and launching new maternal health service delivery areas, such as improving access to services during pregnancy and the postpartum period, or equipping the maternal and child health workforce with new training and resources. So in Arizona, the State Maternal Health Innovation Program created the Tribal Maternal Health Task Force, which includes all 22 federally recognized tribes in partnership with the Intertribal Council of Arizona and the Navajo Nation Department of Health and Dying College. Next slide, please. We're also responding to the need for maternal mental health support with our National Maternal Mental Health Hotline. About 1 in 8 women that recently gave birth report depressive symptoms during the postpartum period. And data from maternal mortality review committees in 36 states show that from 2017 to 2019, mental health conditions were the leading underlying cause of pregnancy-related deaths. These included suicide, overdose, poisoning related to substance use disorder, and other deaths relevant to mental health conditions. and people in rural and underserved areas face challenges accessing mental and behavioral health care services. So we launched the National Maternal Mental Health Hotline on Mother's Day in 2022. It provides free, confidential 24-hour support before, during, and after pregnancy. When a person in need calls or texts 1-833-TLC-MAMA, I hope you all memorize that number, they can connect to qualified counselors that provide support in English and Spanish via voice and text. And the hotline also provides translational services, including in Navajo, Yup'ik, Choctaw, and Hopi languages. And since its launch in May 2022, counselors have supported over 29,000 calls and texts. Next slide, please. You'll see we post notices of funding opportunity on the MCHB website. Please use the QR code to stay connected with MCHB funding. Next slide, please. Thank you for your time this afternoon. I just want to reaffirm MCHB's desire and commitment to strengthening our work with tribal communities. And with that, I'm going to pass it over to Erin Towner, who is with our Federal Office of Rural Health Policy. Erin?
Thanks, Elizabeth. Thanks for teeing us up with the maternal and child health part. And I will kind of delve a little more into the rural piece that you mentioned during your presentation. Next slide, please. So I sit in the Federal Office of Rural Health Policy, which was established in Section 711 of the Social Security Act. We collaborate with rural communities and partners to support community programs and shape policy to improve health in rural America. So we have a role within our agency of HRSA and within the Department of Health and Human Services. We collaborate with other federal partners to accomplish our goals. We also increase access to healthcare for people in rural communities through grant programs and public partnerships. And then we also have a policy piece. We have a policy division that advises the Secretary of Health and Human Services on policy and regulation that affects rural areas. Next slide, please. So the Federal Office of Rural Health Policy, or FORP, as we call it, has supported at least 750,000 people each year since 2011. And we had over 300 grantees in 2023, this past year. And then generally, folks who have our grant funding continue services, health services after their program ends, 80%, so over half. And then here at the bottom of the slide, you can see a list of some of the programs that we have within our office. Next slide, please. And then at this point, I'd like to talk a little bit more about the available funding within FORP. The Rural Community Opioid Response Program Impact grant funding is available now. The deadline for that one is May 6th. So it's pretty close, but you have a couple weeks if you're interested in applying to that. You can find that funding opportunity on grants.gov. And then in this coming fall, in 2024, we'll have the Rural Residency Planning Grant Program, the Rural Health Network Development Planning Program, and then in December and January, Rural Healthcare Services Outreach Program and the RMOMS program, which is Rural Maternity Obstetrics and Management Strategies Program, will open as well. All of these programs are contingent on appropriation of funds for fiscal year 2024, but we do anticipate them being available. Next slide, please. I highly recommend signing up for our FORP weekly announcements. You can find information about funding opportunities there, and then policy developments, research about the rural U.S. and healthcare in the rural U.S., and then policy updates from a rural perspective. Next slide, please. I also want to give a plug for becoming a grant reviewer. This helps us get the rural perspective when we're funding grantees. And it's also a good way to get an insight into how grant applications are scored. So if you would like to register, you can email, well, you can register at this link at the bottom of the slide and then let us know also that you have registered, and email my colleague Lisa to let her know so we can make sure to pull you out of it. Next slide, please. At this point, I want to talk a little bit more about the Rural Communities Opioid Response Program, which is a suite of grants within the Federal Office of Rural Health Policy, which I work pretty closely on. The RCORE program provides direct funding and technical assistance to rural communities to improve access to behavioral health care services, including substance use disorder treatment, recovery, and prevention. And it's a pretty extensive initiative. More than 4 million individuals living in more than 1,900 rural counties across 47 states and 2 territories have access to substance use disorder prevention, treatment, and recovery services that they would not otherwise have without these programs. And last year, we awarded more than $80 million to rural communities in 39 states. Next slide, please. So within the broader RCORE grant program initiative, we've got the RCORE NAS program, which NAS stands for Neonatal Abstinence Syndrome. And the purpose of, and I'm the program coordinator for this. So if you have more questions about this particular funding, you can please feel free to reach out to me after the webinar. But the purpose of this program is to reduce the incidence and impact of neonatal abstinence syndrome in rural communities by improving systems of care, family supports, and social determinants of health. And it's a pretty broad wraparound grant program. So grantees within this cohort are going to reduce structural and system level barriers to increase access to behavioral health care for rural pregnant and postpartum persons and their families, and then also addressing community risk factors and social determinants of health, as that's kind of a broader goal within FORP within the last couple of years. And grantees are also looking to strengthen the quality and sustainability of behavioral health care services for rural pregnant and postpartum persons and their families by implementing coordinated, evidence-based, trauma-informed, family-centered substance use disorder and other services. Next slide, please. So this current cohort within the NAS2 program has grantees within 24 states. We awarded 41 grants this time around. 29 of them had received RCORE funds previous to now. And most of them heard about the funding opportunity through the HRSA news release. So if you're not subscribed to that, I would recommend getting on that listserv as well. Next slide, please. And at this point, I'm going to pivot a little bit to our rural community-based programs. They kind of fall into 2 buckets, direct services and capacity building. So here you can see a list on the left of our programs that provide funding for direct services. There are some that are related to health issues such as black lung or radiation exposure, and then some more primary care related grant funding. And then on the right in that column, you can see some of our funding related to developing health systems in rural areas, and also our Moms program, which is relevant to our topic today, which is rural maternity and obstetrics management strategies. Next slide, please. So our rural healthcare services outreach program is anticipated to open for applications in winter 2024. And likely we'll be starting the project May 1st of 2025. The purpose is to promote rural community healthcare services. It's for 4 years, and you'll get up to 200, or successful applicants will get $200,000 per year. And the activities that folks who receive this funding will be doing will, they'll be improving and expanding healthcare delivery in rural communities, aiding rural healthcare and project needs, collaborating with partners to deliver care, applying models of healthcare tailored to communities' needs, and improving health outcomes. So pretty broad, a lot of room for you to do exactly what your community might need to do. Next slide, please. So folks who are eligible for that particular grant program are domestic, public or private, nonprofit, and for-profit entities. So that includes federally recognized tribes and other tribal organizations. And all of our funding within FORP has to go to increasing healthcare access in rural areas. But for instance, for example, you could be an entity that is in an urban area, but is providing services in a rural area. So just keep that in the back of your noggin if you decide to apply for any of our funding. And most of our grant programs require our grantees to work in a consortium. And that way it gives you a good overview of the community that's being, that the health programs are being implemented in. Next slide, please. And on this slide, this slide is just an overview of our pending rural community-based funding. So a number of these are opening in spring 2024. So the one that is currently available is the Radiation Exposure Screening and Education Program. That one, that application cycle is closing May 29th. So if you're interested in applying for that, I would highly recommend checking that out on grants.gov. If you are in the Northeast, the Rural Northern Border Region Outreach Program will also have funding available in spring. So you may want to look into that as well. And I would just encourage you to check out some of these other programs that we have funding dropping for in the future as well. Next slide, please. That's my time, guys. Thank you so much for listening. If you have questions about anything I mentioned today, please feel free to reach out via email or phone. And at this point, I want to introduce Diane from the Menominee Indian Tribe of Wisconsin. She's going to talk a little bit about her grant within the NAS2 program and the great work they're doing.
Thank you. Okay, I'm gonna share my screen here. Okay, so like Erin mentioned, my name is Diane, and I am talking to you from northern Wisconsin, a little bit about our newly started work with the Neonatal Abstinence Syndrome grant. So just to acknowledge the land, I am talking to you from the beautiful Menominee Reservation, again in northern Wisconsin. We are the only Wisconsin tribe, or they are, I am sorry, that is inhibiting their ancestral land. At one point in time, the Menominees did own the whole state of Wisconsin, part of Illinois, part of Michigan. So treaties reduced tribal lands from about 10 million acres to its current Menominee County, Menominee tribal boundaries, which is about 235,000 acres. Our little area maintains the country's largest sustainable forest. We have pictures from astronauts to prove that, so that's pretty cool. Those of you that recently watched March Madness did see our finest products. We do supply a lot of floors for the NCAA tournaments. There's about 9,000 Menominee tribal members, 4,000 of those who reside on the reservation. Our tribal members have been shown to be very resilient, and when they do the health rankings in Wisconsin, we are always ranked 72 out of 72 counties, and we are working on that all the time. So in September, we did receive our grant, the HRSA Health Resource and Service Administration, our core Rural Community Opioid Response Program, NAS grant, so neonatal abstinence syndrome. And again, the goal is to reduce the incidence of neonatal abstinence syndrome in the community. So we've really been at this for only about 8 months now. I think we've made some great progress, but you know, our work is really just starting. So basically, what is neonatal abstinence syndrome? It is a group of conditions caused when a baby withdraws from certain drugs he or she is exposed to in the womb before birth. It is most often caused by moms using opioids during pregnancy. The typical symptoms of NAS, tremors, irritability, poor feeding, high-pitched cries, poor sleep, very sometimes rigid muscle tone. Tachypnea is the rapid, slow, shallow breathing, a lot of nasal stuffiness. So these babies are often very hard to console. Some of them need very minimal stimulation. Some of them need constant, constant contact, being held very closely. So this does, these symptoms usually start coming on, just like an adult would start experience withdrawal symptoms, usually 2 to 3 days, after birth, as the baby is starting to withdraw from not having those opioids. So our partnership is between the Menominee Tribal Clinic and the Theta Care Medical Center in Shawano, Wisconsin, which is about 10 miles from our clinic. That is where our doctors have their practicing privileges, and that is where the vast majority of our babies are born. So just to give you a little bit of information on how very rural we really are, Menominee County, the population in total is about 4,300 people. We are the least populous county in Wisconsin. Over 80% of the residents here are Native American. There are no stoplights at all anywhere in our county, nor a 4-lane highway or anything else. The population of Shawano County is about 41,000. The population of the little city in Shawano, which is the only city in Shawano County, is about 9,000. We have this little rural hospital that is a 25-bed hospital. And when we started looking at all of the issues going on with substance abuse here in the tribal community, babies that were born to moms taking medication for opioid use disorder were not even being born at the Shawano Hospital. So much work has been done already behind the scenes to get our moms, birthing close to home so families can be involved in this process. So again, like Erin and Liz were talking about all the opportunities, I am here to say, please don't be discouraged if you say we are too small. Like I said, I am talking to you about a very, very rural and small population. So please don't let it discourage you from applying for any of those opportunities. So the first thing that we tried to implement in our clinic was to just start screening all of our expected parents about substance use. We started using the 5 Ps at the clinic, which the screen is over here on the left-hand side of the screen, but we're asking the ladies if their parents had a problem with alcohol or drug use, their peers, their partner, they themselves, if they've used in the past month, and then we do ask specifically about opioid use as well. And we do know that just about every single one of us could say yes to one of these questions on here, right? So this is basically used as a conversation starter. We want to know, do they have a sober environment to take their child home? Are they going to have some good support when they take that child home. Of course, if they themselves are using, what sort of help can we get? You know, we are lucky enough with both tribal funds and county funds to be able to send people to residential treatment, with pregnant moms taking priority. So, you know, we're not so worried about, you know, yeses outside of the actual parent questions, you know, but we are wanting to know, what is their support? What environment will they be raising this child in? We do these 5P screening every trimester. The doctors have it worked out. When they do a certain thing that trimester, the 5Ps is just attached to it. You know, the initial OB, and then when they have their ultrasound, their daily ultrasound, and then when they have their tetanus shot. So they bring us in both times. We've taken nursing completely out of this. It's myself and one other substance abuse counselor here in the medical department that is doing this. Also within their first trimester, we do an SBIRT screening and the T-SBIRT screening. So this is a trauma screening, brief intervention and referral. This is the questionnaire that is a little longer. It's going to ask about all the ACEs. It is going to ask about the social determinants of health. It's going to ask about coping strategies, you know, healthy coping strategies, maybe some that are not so healthy. It's going to ask about their specific stressors. And this is the screen that we are using to kind of help recommend behavior health services to a lot of our moms as well. You know, we know a lot of our moms do have some behavior health struggles. So we've made this pretty just across the board. Everybody is getting it. We're not picking and choosing. And they also get an incentive when they talk to us. So even in these few months that we've been doing this, we do hear, oh, do we get to pick a prize today? Do we get to talk to the ladies and pick a prize? So, you know, it is already making a little bit of an impact here with our moms. Also, we do know that we want to ensure that our pregnant moms that need it have access to medication for an opioid use disorder. For years and years, methadone maintenance treatment has traditionally been the standard of care for the opioid use in pregnancy. In the state of Wisconsin, I am not sure about every state, but in the state of Wisconsin, methadone can only be given by authorized certified programs. And so our nearest methadone treatment clinic is about 45 minutes away, depending where you are on the reservation. So we know, hey, we've got to do something about this. You know, we have to bring these services a little bit closer to home. So we have started over the past few years prescribing the buprenorphine, the Suboxone, and we do have 4 providers here at the clinic who are very comfortable in doing this. 3 have caseloads. 1 just kind of helps when people are out of the office or on vacation. But, you know, we know how important it is, because a lot of times, sadly, these NAS babies, the moms aren't always showing up for their prenatal care, right? They're showing up to deliver at the hospital, and we are trying to get the word out. You know, please, non-judgmental care is available here, right here at our clinic, no matter what your story is. Please, please come in for those prenatal appointments. And we also want to ensure moms get care after, you know, during the postpartum section as well, because like was mentioned earlier, the huge stats on, you know, postpartum depression, take that along with the depression that goes with being off of things like opioids and methamphetamines. And, you know, our moms are really struggling. And a lot of times it's the motivation of the pregnancy that helps them stay sober. So we know how important it is to really follow them all the way through, even to the postpartum status. So Suboxone in our state can safely be prescribed in family medicine and tribal clinics. Again, 3 of our physicians have that active caseload. And here we're looking at, you know, the stats. total amount of morphine that has to be used for the babies that are born with moms using Suboxone, usually 0 to 1 dose. Duration of withdrawal, you can see much less. Hospital stay, again, much less. And we have one of our doctors here who really advocated for our moms to be able to deliver in that local hospital, our hospital 10 miles away. So those things have been worked out, and we're having some very healthy, happy babies born in our local hospital. Working a little bit with our hospital, babies are now kept 36 hours. 96 hours. They're being kept those couple extra days to monitor for symptoms of withdrawal, because we've all gone through withdrawal with adults. Sometimes those symptoms don't show until about the 3rd day. And then mom and dad are taking baby home and aren't prepared, for what's coming. So now typical babies born exposed to the Suboxone are going to be kept for 96 hours. The babies are swaddled, they're kept in that flex position. The environment is very minimal stimulation, low lighting, low noise level. We try to avoid abrupt changes in the infant's environment. The hospital even has the volunteer rocking program now, so the babies can be, they can be held and rocked, even if mom has to get a little bit of rest. We encourage that skin to skin care with mom. And sometimes we have to limit all sorts of stimulation if there's any distress, and offering the pacifiers for comfort to the baby as well. Another change that the hospital did is they want to start assessing babies eating the eat, sleep, console method of assessing babies. So this approach is how we can manage those opioid exposed newborns. The Eat Sleep Console, compared to the old Finnegan scale, which was developed in the 1970s that a lot of hospitals are still using. Newborns assessed with the Eat Sleep Console were discharged about 6 to 7 days earlier and had about 63% less likely to receive medication, mainly morphine, for the treatment of their withdrawal symptoms. And basically, this assessment is, can the infant eat at least 1 ounce? Can the infant sleep at least 1 hour? Can the infant be consoled within 10 minutes? And they start assessing within 4 hours of birth, and they reassess every 3 to 4 hours. Another thing that we are doing here is we have recently partnered with the Waking Women Healing Institute, which offers full spectrum indigenous doulas. They are located about 10 miles in the other direction. We're working with the hospital to see supplies that they may need for these traditional birthing practices. And we want to provide, spiritual, emotional, and physical support through their whole cycle of reproduction, even before conception. And we are truly hoping with breaking the cycle of trauma that we are ideally going to prevent substance use disorders in future generations. Other resources that we've been talking to here in our community, right inside of our clinic, we have a women's personal health department. We have First Breath, lactation consultant, birthing classes, and we do have a behavioral health program right in our clinic that we use very, very often. Menominee County, the building right across the street from us, has a Birth to 3 program. We have substance use disorder treatment right in our community as well. Help Me Grow and Welcome Baby are programs through the hospital that all of our patients are eligible for. We are working with recovery coaches here in our community. And we are also getting some incentives for our parents that can attend parenting programs such as Triple P and Positive Indian Parenting. The little basket you see here was just a recovery walk done in Shawano County, and that this was kind of our advertisement and basket for the basket raffle there, you know, to kind of bring exposure to our program as well. And so finally, just thank you for having me today. Like I said, our efforts are just starting. I hope we continue to have more exciting things to share with everyone. You know, we're trying to get out in the community that early and regular prenatal care can improve those outcomes. We're trying to parent with our families, you know, not direct them, but parent them. And again, if you're considering applying, please do, because there is no community or no project that is too small. Thank you.
Thank you so much. And next, we will move to our next speakers. We have Caroline Bloss, the Recovery Products Director from Healthy Acadia, and Kamisha Norris, a Community Health Navigator and Youth Engagement Coordinator from Healthy Acadia. Thank you so much.
Thank you. And thank you all so much for being here and for allowing me and my colleague, Kamisha Norris, to present to you today. My name is Caroline Bloss. I'm a licensed social worker by training, and I work for a nonprofit called Healthy Acadia, located in Down East, Maine. At Healthy Acadia, I serve as the Recovery Projects Director, and my colleague, Kamisha, works as our Prosper Community Health Navigator. Kamisha will be presenting in a few minutes. So I'm going to give you a quick overview of our organization, so to orient you a bit, and then Kamisha will dive into discussing the incredible tribal work that she does. Healthy Acadia is a nonprofit community health organization with about 60 employees, and we are located in Down East, Maine. As you can see on this map, Down East, Maine is comprised of Hancock County and Washington County, and that's indicated in yellow. Healthy Acadia's mission is to empower people and organizations as we build healthy communities together. And our vision is to have vibrant communities where people thrive and healthful resources are easily accessible. To bring this vision to fruition, we work on a broad range of community health initiatives that support our service area. The scope of Healthy Acadia's work encompasses 7 areas of focus, but for today's presentation, we're going to focus on one, and that is our substance prevention and recovery area. Healthy Acadia relies heavily on federal and state funding to do the work we do. In 2021, we were awarded HRSA's Rural Healthcare Service Outreach Program funding, which enables us to offer the Prosper program. Our Prosper program provides care navigation for pregnant women and new moms with substance use disorder. As I stated earlier, we serve Down East, Maine, which is comprised of Washington and Hancock County. In Washington County, there are 2 tribal reservations. There's Indian Township Reservation, and there's Pleasant Point Reservation, also known as Zabaik, that make up the Passamaquoddy Nation. The original plan was for our Washington County Navigator to serve both reservations. We were naive in this thinking. We learned that tribal communities have their own unique needs and challenges, and that it's essential for our navigator to be culturally competent or ideally connected to the tribe in some way. And these are, the photo on the left is the front page of our Prosper program brochure. And then the photo on the right is myself, our Washington County Navigator, and then Kamisha's on the right. Again, she's our Tribal Prosper navigator. I'm going to now hand off the presentation to Kamisha.
Hi, everyone. I'm Kamisha Norris. I am from the Passamaquoddy tribe. I have called both Zebayeg and Indian Township home. For over 10 years now, I've been working in public health. Right now, as Caroline told you, I'm working as a community health navigator. And my heart is in this work because, like many of us here, I've seen how substance use can hurt families. It's touched my own family deeply. My mom passed away in July, and she struggled with substance use disorder since I was 8 years old. And witnessing her struggles firsthand has deeply impacted me, but it also fueled my passion to help others in similar circumstances. I know the pain of addiction, the fear, the feeling of helplessness, but I also know that the strength that lies within the families. That's why I'm dedicated to working with individuals and families struggling with substance use. I want to be a source of support, a guide to healing, a voice for those who may not have the strength to speak for themselves. And I get what it's like to live in our community with all of its strengths and its struggles. I've studied everything from science to psychology, health education. I even became a certified K-12 health teacher because I believe that we need to teach our kids young how to make healthy choices for their future. Most importantly, I believe in our people, and I know that we need to start treating substance use with compassion, not judgment. Especially true for moms. They need our support. I'm a mom. Those are my 3 lovely daughters in that picture. And I know it's hard to be a mom. Not to mention, I couldn't imagine how hard it would be to be a mom and battling addiction at the same time. Our communities are built on strength, resilience, and a deep commitment to future generations. Substance use disorder threatens the health of our moms and the potential of our children. And this is something we cannot ignore. Imagine our reservations being a place where hope shines bright. Imagine recovery blossoming and new lives taking shape. Picture our children growing up strong, healthy, and untouched by the darkness of addiction. I do believe that Prosper is bringing us closer to making that a reality. In this picture here, there's my oldest daughter in the front, and then my middle daughter in the back with her white t-shirt on. They did the Warrior Run last year for our Indian Days. Now, tribal communities often face unique and difficult challenges. When addressing substance use disorder and its impact on mothers and children, here are some of the biggest obstacles. Limited access to treatment. Far too often, healthcare services, including those specifically for substance use disorder, are simply not available in tribal communities. This leaves pregnant women and mothers without the help that they desperately need. Cultural factors. In some communities, traditional beliefs or practices can make it hard to discuss substance use disorder openly, and it makes it hard for them to ask for the necessary treatment. We also have a lot of historical trauma. The legacy of trauma runs deep in many tribal communities, and this pain can contribute to substance use disorders. My commitment is to meet each parent or caregiver with understanding and support, regardless of their situation. This means connecting to them in ways that make them feel comfortable, whether I connect with them through Snapchat, Facebook Messenger, Zoom, phone calls, text, home visits. Sometimes I've even met them at the playground or picking up our kids at school. We'll stop and talk really quickly. My job isn't to push agendas or dictate solutions. My role is to simply listen and only offer advice when asked, and also use motivational interviewing to help them discover their own path forward. Shame is a crushing weight for families dealing with addiction. They feel guilty, they fear the judgment of others, the shame forces them into hiding, and that isolation can be devastating. They might stop looking for help or avoid applying for jobs. Fear of judgment stops people from taking the very steps that could save their lives for their families. Prosper is different. Prosper is a safe haven. It's a lifeline, a place without judgment where they can finally feel supported, where there's proof that they're still caring people. The simple act of caring can change everything. As a navigator, my job is to give families one-on-one support with compassion and respect. I help with everything from finding treatment to navigating complicated systems, education on parenting, parenting with addiction. I offer emotional support. I actually teach a parenting class called Fatherhood and Motherhood is Sacred. Our goal is to fight the shame and stigma. We want to stop women from being punished or pushed aside when they're bravely asking or seeking treatment for themselves and for their families. Let me tell you a story. So this family right here is from our community. They struggled with addiction. They have faced a mountain of challenges, doubts, the stigma of their past, feeling all alone, and then they found Prosper. This program met them exactly where they were. It provided the support they craved with understanding and respect for their culture. I'm going to play you an audio clip, and this is Allison. She's shown in this picture in the back. You can kind of see her behind the playground. This is her with her 9 sons. She shares her gratitude. And then in the next slide, her partner Yates is shown with 2 of their children, is also making a powerful testament to Prosper's help.
Yeah, you just believe in us, and no one else did that. Like, no support, no one believed in us. They just labeled us and kept right there.
Seeing like the model, the family model, the native model that it's based on, where like the family and the kids come first, I think was like really, really important.
Now we're about to hear one more powerful story. This is Amanda's story. Her story is one of courage and hope. She faced addiction head on, and with Prosper's help, she's building a brighter future for herself and for her family. Even more incredible is that she's now paying it forward, helping others on their journey, and this is what Prosper's all about.
So about 1.5 years ago or so, I ended up having some problems that came up, and I kind of fell off the wagon for a little while and started using again. But then I got pregnant and I got sober, and I got involved into the Prosper program. And if it wasn't for Kamisha and the Prosper program helping me to get these doctors to help me to get onto the straight and narrow, I wouldn't be where I am again today. With the Prosper program involved with me and my family, she was able to help me with my medical problems, with my issues with abuse at the time. She also helped me write up letters to the tribal government in regards to problems that were going on with a director, a specific director that was taking place and that was abusing her power. If I didn't have the Prosper program helping me and backing me, I probably would have went fully off the wagon and I would have really started using again. This program is very important to my family and has been very important to the communities around here onto the reservations. Indian Township, Pleasant Point need this program is because there is a lot of alcohol and drug problems with families or within the family or the mother and father of children who are, being raised within the community. As a result of getting the help from the Prosper program, I ended up getting the help that I needed because of Kamisha and because of the Prosper program. I'm now currently going to be starting a position as a navigator, just like Kamisha. And I do got to say, without that, I wouldn't make it. I wouldn't have made it where I am today. I wouldn't be sober today. I wouldn't have my head level today. I wouldn't be where I am today.
So there's a few key things that make Prosper so effective. Privacy. We understand that seeking help can be scary, and we want to make sure that they feel like their information is safe with us. Empathy. We will meet them exactly where they are. We offer them respect, understanding, and hope. Access. Everyone deserves support, and we're here, we're easy to find, and we're ready to help anybody without judgment. It's really important to remember that addiction does not make someone a bad person. It's a disease. Too often people are judged or labeled as bad parents or criminals. I've even heard heartbreaking stories, like a mom who felt like she was a better parent when she was actively using because she could function and she wasn't worried about her next fix. Seeking help meant risking losing her children. So tragically, it felt easier to keep using. And we need to understand that these are the complex realities of substance use disorder. This here is my friend Kia and her children, Stephen, Nidab, and Linda. They're holding a photo of Stephen, aka Steve, who lost his life to an overdose in 2021. Steve was a father, a husband, and a Passamaquoddy tribal member. Stephen earned 2 associate's degrees, one in business management and the other in office information systems. He also had a diploma in computer technology. Steve became an assistant at Washington County Community College for the TRIO Student Support Services. He was a member of Phi Beta Kappa. Steve loved the outdoors and enjoyed photography, hunting, fishing, and working in the woods. He was always happy and had a positive outlook on life. Steve was always ready to help anyone in need. When addiction took over, it started hurting his family, his job, and sadly led to his death. But even with the attempts at recovery, he just couldn't escape the addiction. His children and Kia live on, carrying this heartache and the challenges growing up with addiction close by. Addiction is a disease. It's not a measure of someone's worth. Steve's tragic overdose is one of many in our community, showing us the deep crisis that we face. So we're fighting for a community where those struggles with addiction need to feel safe asking for help. And here's why that matters. Breaking the stigma. When we stop judging, people stop hiding and they're less afraid to seek treatment. Ending isolation. Addiction thrives on isolation. Support means connection, a lifeline of loneliness, a lifeline out of loneliness. Building self-worth. Compassion helps people believe in themselves again, and it's the first step towards recovery. Stronger families. When a parent gets healthy, the whole family benefits. Helping our community. Fewer people in crisis means less strain on hospitals, social services, and honestly, less strain on all of us. Boosting the economy. People in recovery become productive workers again. That strengthens all of us. Strong tribal communities are essential for preserving cultural heritage, fostering self-determination, promoting health and well-being, and ensuring a vibrant future for Indigenous people. While we focus on the crisis of substance use disorder, it's important to also celebrate the richness of the Passamaquoddy culture and the tribe's determination to overcome these challenges. Change is possible with the right support. And Willie One, thank you all for giving me the opportunity to share this information.
Thank you so much to all our speakers today. Thank you, Diane, Caroline, and Kamisha. That was really wonderful information. And thank you for sharing your personal stories and experiences from your communities as well. Thank you to our federal speakers who shared resources, and everyone's time today was greatly appreciated. We will now move into a question and answer session here. We've had a couple folks ask questions in the chat. Please feel free to continue adding questions in the chat. My colleague Amy mentioned earlier that if we don't get to all questions today, our speakers have graciously offered to help us follow up via email with those who have registered. So we will get your question answered either today or in a follow-up email, but please continue to submit questions if you have them. We do have some questions here that I'd like to direct. The first one to Dr. Blom. Is there any urban Indian organization representation on the Tribal Advisory Council?
Oh, that's a good question. We do not currently have representation. We run our committee as a federal advisory committee, and we have an exemption that allows us to work with elected tribal leaders of tribal nations, or they can designate someone who works for the tribe to serve on the TAC. We do, however, work with the National Center for Urban Indian Health. So we have met with Chandos Colleen, Meredith Ramondi, and spoken with them about efforts related to urban Indians, because we know that is a huge proportion of the population. So we do have an interest in that, and I hope to incorporate that into our programs.
Thank you, Dr. Blom, for sharing that information. We had another question for Liz from Michael Rosenthal, who asked, can an urban Indian organization use Healthy Start funding to do home visits to Native Americans living in urban areas, but not Indian country?
Thanks for the question. The answer is yes. The Healthy Start program is a community-based program, and when candidates apply to the program, they define the project area of the population that they want to serve. So as long as the population area is defined in the application, and the application is approved and funded, then yes, absolutely.
Great, thank you. And I noticed some people asking for links in the chat or additional information about how to access grants. I see that there have been some links dropped. Any links that were part of the PowerPoint today, we will be sending out the PowerPoint after today's session along with the recording. Anything that's hyperlinked, you'll be able to access on there. Otherwise, grants.gov is your best resource. If you're able to find the grant on there that you have a question about, you can always reach out to anyone on our planning team today, myself or any speakers who shared their email information in the chat if you do have additional questions. But every federal funding opportunity can be found on grants.gov, both current and forecasted. So that's one of our most recommended resources for where to go for new funding and eligibility information. I also have a question here that is for the tribal organizations who spoke today, who were both recipients of Federal Office of Rural Health Policy, or FORP funding. And it's to get a little more background on the federal funding application process. Maybe if you could share a little more about what the federal grants application process is like, how you learned about opportunities, and maybe what you would recommend for resources or application tips. So that would be for either Kamisha or Diane or Caroline, if you could share a little bit more about what that application process was like.
You want me to jump in? Okay.
Yes.
Hi, everyone. Just something that I feel strongly about that we did learn during this process. So the actual application itself was very similar, in my opinion, to other HRSA applications that we applied for. But what we did learn was what we put on paper absolutely transformed later down the road. It was an organic learning experience where we had to be very flexible and sort of pivot when our expectations weren't being met or lessons were being learned. So I would say, while your intentions are great and they're on paper and you got your funding awarded to you, always hold the space for allowing things to change a bit, because we've rarely had a grant that has stayed very, very, very true to the application. So thank you.
Thank you. And Diane, did you have anything to add about your experience?
We are very fortunate here to have a team of grant writers. Worked very closely with them, but they're the ones that kind of put the final project together. But just like Caroline just said, you have to be ready for those little roadblocks you're going to get. You always kind of have to have that plan B, and you have to, map out, because when they are asking you to partner with agencies and to use other resources in your community, you can't be certain, what they might really want to do. So, we can just to sometime remember, we can only control what is going on right here. And, like she said, to pivot when you have to, and just say, all right, we tried that, and it maybe wasn't the best exact route.
Thank you for sharing that. And I think one of the things we really wanted to express today is our HRSA colleagues that were on this planning team. We're here as resources. You can reach out to any of us. The map that we shared at the beginning of the presentation that has all the regional administrators for HRSA, their contact information is linked at the end of this presentation. Any of them would be happy to hear from you and answer questions. But we want you to hear from colleagues and know it's possible. And Diane, I think you did a really great job during your presentation, just highlighting, even if you're smaller, even if you're more rural, we want to get the funds out across the US to different types of organizations doing this type of work. So we want it to feel accessible to everyone. So if you have additional questions, please feel free to reach out and maybe lean on each other in the community too. And we appreciate you all being here as a resource for other partners as well. So thank you for sharing your experiences there. We do have another question from Carrie, who is curious to know the rationale and benefits of taking nursing out of 5Ps screening. Also, what type of rewards are given to patients for their honest participation in the program?
The reason that we took nursing out of this is our nurses are very overworked. And if we're trying a new initiative, sometimes just it sells really well when you could say, this is really not going to be any more work for you than sending me a quick, message through the EMR saying the patient is ready, or what have you. I would have no doubt that our nurses would be qualified to do the 5Ps. That is not why, but I think that you just get so much better buy-in when you can say, this is not going to be additional work for you. And things that we are giving for incentives, just basic things that people are going to need for babies. We've got diaper and wipes, baby care items, some household items, some health and beauty aids for mom. Actually, our most popular item is laundry soap. For some reason, it's a little costly, but when we refill it, that goes right away. So it's just some basic things to just help them, with their basic needs at home.
Thank you. And another question here that looks like it was resolved in the chat, but I just wanted to read out in case others were curious. Katie asked, is it common for these grants to cover wage for staff? For example, my wage and another full-time RN right now, our wages are covered under a grant from the state of Minnesota. We need another RN, so looking at how we would fund that position. And Caroline shared that for her specific funding opportunity, yes, we used our funding to cover the cost of our navigators. So some of the HRSA grants do include that as an appropriate use of funding. What I'd recommend on grants.gov, when you take a look at the application package, there's always going to be a project officer or a point of contact linked there with their phone number or their email address. They are there as a resource to you to ask those specific types of questions. They can really go through and determine whether you meet eligibility and how you can use funding during the application process. And I think I think that's all the questions we have in the chat. If we get any more as we're finishing up the session, we'll be sure to pass them along and get those answered for you as part of the follow-up email that will contain the recording, these PowerPoint slides, and the PowerPoint slides of all our presenters today. So again, thank you so much for your time today. We just have a couple more updates. I'm going to pass it to my colleague Bree to share some upcoming events that you all might find of interest from HRSA IEA, some closing remarks, and a short poll. This really helps us to guide future external webinars and what would be most helpful to you all. So please stay on. We appreciate your time.
Thanks so much, Rachel. Hi, everyone. My name is Brie Colangelo. I also work with HRSA IEA. So as Rachel mentioned, I just wanted to share a few things with all of you. One is regarding upcoming events that we are hosting. So you will notice on the slide, we noted, who is hosting the event by region. However, these events are all open to everyone, no matter where you're coming from. So please, take a look at these. Again, we will be sharing the slides. All these links will be available to you so that you can register. We're also going to share them in the chat. But a lot of grants, webinars that I think would be very useful. So you can just get some insight on applying for funding that's available. We also included a few of the tribal affairs events that are taking place that Juliana mentioned during her presentation. And then lastly, our HRSA colleagues with the Office of Federal Assistance Management are hosting a Healthy Grants workshop. So again, included a bunch of links of some resources that are available, as well as registration links. We also, you'll notice we put up the poll questions. If you could just take a few minutes, as Rachel mentioned, this is just really important to get your feedback on your attendance and how you felt about today's webinar, and give us ideas of what was most helpful to you to hear about today. What type topics, would you be interested in learning more about in the future? How are you feeling today, and with engaging with HRSA about tribal issues? And then lastly, if you're interested in connecting with any of your IEA regional offices, you can put in your information in that last question. Next slide, please. So as mentioned earlier, you saw a map with all the different regions. This is to give you the email contact information for each of our regional offices, as well as the Office of Tribal Affairs. Please feel free to reach out to them if you have any questions about programs, about HRSA information, resources, funding, or if you just simply want to connect. We'd love to hear from you. Again, these will all be made available to you when we send out the slide deck. Next slide, please. These are just a few HRSA resources. So the first one is HRSA's website if you want to learn more about our different programs. The second is where you can look up different HRSA grants that are available right now. And then lastly, the data warehouse is a great tool if you're applying and you want to find more information about HRSA's funded programs. It has maps, reports, and a lot of really useful data. Next slide, please. And then lastly, you can connect with HRSA on our different social media platforms. I do want to note that in the slide deck that we will provide to all of you, we've included an appendix. This will include several resources on maternal health, HRSA resources on maternal health, workforce, behavioral health, and the grants process. So please take a look at those. We're also including a list of notice of funding opportunities and links for you to access those notice of funding opportunities. And so with that, I just would like to, again, thank all of our wonderful speakers, Chief Atkins for providing the prayer, my HRSA colleagues, Juliana, Erin, and Elizabeth. Thank you so much for sharing your expertise on the different HRSA programs. And then thank you to our wonderful grantees, Diane, Caroline, and Kamisha, for just sharing your stories, your successes, your challenges, and for taking the time to be with us today. I'd also like to thank all of you for joining us today, and hope that you all have a great rest of your day. Please don't hesitate to reach out to us if you have any remaining questions, or just simply to connect. And so with that, please, if you haven't already, complete the poll questions, and I hope you have a great rest of your day. Thank you.